Oh, yeah. Dr. James Taylor is an emergency physician with 30 years' experience. Major appointments have been in our nearby hospitals, Monash Medical, Alfred Health, a specialist and director of Sandringham Hospital Emergency Department for 15 years. Now retired from clinical practice, he continues to teach young doctors, is a keen gardener, enjoys his grandchildren, a lucky fellow, and is a regular yachty at Sandringham Yacht Club. His talk is When Things Go Wrong, a life in emergency medicine. Dr. James, thank you.
Thank you very much. So, I've been asked, will I sing? But no, I won't. The other James Taylor sings a lot better than I do, and I won't spoil his repertoire. You can see the irony in this. Why would I choose a life in emergency medicine? Clearly something went wrong. But that's my joke. So there we are. What I want to do is have a chat with you about when things go wrong, why emergency medicine. I hope none of you ever need to visit an emergency department. I always quote, doctors and hospitals are best avoided if you can. But I've spent 40-something years in emergency medicine as one of the early adopters, and now delightfully retired because I've done my time. But I want to talk a little bit about getting the right connections, and you'll see why I use that title as we go into it. I'll explain a little bit about triage and why that can work in your advantage or to your disadvantage, so you'll take some tips home from that. Why do we have specialist services? And I don't mean of all specialists, but a specialist service in emergency medicine. And I'm going to talk a bit about flow, and I know I'm talking about to a whole lot of men, and men our age all know about flow, but that's not the flow I mean. I mean more about business flow. So, but first, who is this gentleman, and why would I be grateful to George Clooney? Because very famous in the ER series. So, I make the title Emergency, Not Casualty. Now, I'm sure when you guys were young, you would have thought, okay, well, I could go to a casualty department. That is no longer politically correct. We have emergency departments. We are specialists in emergency medicine. The difference is nuanced, but a casualty is a nameless, faceless number in a military disaster, where if you or I were to be a patient in an emergency department, we'd want to be considered as a person, not a nameless, faceless casualty. That's the first part of it. The second part is, 200 years ago, before hospitals really evolved into a public service, they used to have what was called a casual room, where people could walk in off the street, mostly poor, no connection, no family, no wealth. They could walk in off the street we're talking Victorian England, Victorian London, and get some service at the hospital, mostly for surgical issues. So if they had appendicitis or something like that. Because 200 years ago, if you were part of a family with wealth and connections, you would have your family physician, general practitioner, and you would go and see them first, and they would then refer you into the hospital. So people with means were referred directly into hospital, and it was just the casual people coming in off the street that went to this casual room. 200 years later, I think our system is a lot better, although there are still a couple of famous hospitals around the world. One in particular, the Mayo Clinic, does not have an emergency department. You have to be referred directly into the Mayo Clinic, and it is one of the premier health facilities in the world. However, overall, our system works better, and I hope to explain why. So, most of us, if we go to an emergency department, are going to walk in, or go with friends, family, go by ambulance. 20% people will arrive by ambulance. Maybe your family doctor has referred you in. Maybe your chemist has rung the hospital and said, I've got somebody here with some issues with their medications, you need to see them. Or maybe the pathology lab. You've had a blood test and the pathology lab have rung up and said, Mr. XYZ, his result is way off the scale, you need to see him. So we've already got half a dozen different ways of arriving at the emergency department, and with half a dozen different ways of having an opinion. And this will come back, the opinion, and why that's important, and why it could be in error. So that's why the title, When Things Go Wrong. So all these different people have an opinion. The ambulance staff, and I'm in full respect to the ambulance, will say, well, I've picked up Mr. Jones and I think he's having chest pain from angina. And that's quite appropriate. They're well trained. Angina is something they could well know about. But they were bringing Mr. Jones to hospital with the label angina. And that has consequences. Good consequences, sometimes bad consequences. So, but the important thing is the patient comes first. And I want to empower all of you, should you ever need to visit an emergency department, make sure that you're getting the service that you require. It should be in your language, by which I mean, non-scientific, non-jargon. It should be given in an appropriate format, and it should be information that is accessible to you. Please never come away from an emergency department saying, well, the doctor said a whole lot of things and I only picked up one or two. It's very, very common. Because doctors are in a hurry, the nurse is in a hurry, they send you home with a pile of notes, and that pile of notes might be indecipherable to you. I'm sure all of us, my hand's going up, have visited the GP. Just a normal appointment, and you come away thinking, now what did he actually mean by all that? And that's your GP, who's somebody you know well, let alone the emergency doctor, who you probably only get to meet once, and all the chaos of it. But please make sure you're the number one person. So, you go to the emergency department saying, I want to see a doctor as soon as possible. Yeah? Something like that. That's why you're going there, to an emergency department. You haven't woken up in the morning saying, oh, this is what I'm going to do to spend my day. This is something unplanned, but clearly your message is, I want to see a doctor. So what does the hospital do? First, they make you see a reception clerk. Second, they make you see the triage nurse. They're not the people you've wanted to see, but unfortunately, because of processes, we need to know who you are, have you been there before. And it's amazing how many records from the emergency department will have the same person but under 5 different entries, because somebody's got their date of birth wrong, somebody got their chosen name wrong, are you a Jack or a John, get the middle name wrong, an N initial, not an M initial, and all these things show up on the computers, 5 different people. And then obviously we can't access your notes from before if it's not correct. So the reception clerk actually has a very important role, but I would point out it shouldn't delay you getting treatment, knowing who you are. And this is unfortunately where the hospital computer system is so rigid, black and white, you can't enter through the next stage till it got all your details right, including your Medicare number. And in my world, that's crazy. You should be treated for who you are there and then later on, when they've got time, make sure that they've got the right you. But you'd be surprised, there'll be many different versions of you on the hospital computer, and that's perhaps just at Sandringham, and then there's another one at the Alfred, and then there's another one at Monash, and they all have different systems. Although I tell a story here, because Sandringham and Alfred have the same computer system, but you'll have different numbers at the different campuses. Crazy. I'm sure many of you have had IT in your background, and you could see there should be a simple way around this. New South Wales has a simple way, Queensland has a simple way, Victoria has one of the most complex computer systems in the health system. Unbelievable. Anyway, the triage nurse has a very important role, which we will go into. So why triage? Most of us would think, well, I'm first in line, I should be first seen. And that's quite appropriate for all sorts of things, except in emergency medicine. Clearly, we have to have resource allocation, so the really sick people get treated first, and if you can wait half an hour to be seen, that's fine. If you can wait an hour to be seen, Okay, that's fine too. If you can wait 2 hours to be seen, well, that's less fine, but maybe that's appropriate. I will give you a little insight in a minute. But it comes from a military background. So Baron Larrey, L-A-R-R-E-Y, Napoleon's favourite army surgeon, to his credit, invented the field ambulance in the military setting and revolutionised ambulance and triage. He invented the triage system 200 years ago. Remarkable. And we are grateful to that ever since. Doing the greatest good for the greatest number, and also getting people quickly to where they can be seen, treated, irrespective of their rank. And that was the issue that Baron Larrey had to overcome. Because long enough ago, if you were an officer, you'd get treatment. If you're a soldier, you were left to take your time. But Baron Larrey turned that around, and obviously the French army did very well for 20 years. Greatest good for the greatest number. So there is some science to it. We have the Australasian triage scale. It's not a world first, but it's very close to being a world first. 40 years ago at Box Hill, and then at Ipswich, they refined it again. It used to be a 3-level scale. Ours is now a 5-level scale. All of Australia, New Zealand, the UK, Canada, most of the USA now use a triage system much the same. Sometimes 4 levels, sometimes 5 levels. So if you're deemed to be Category 1, immediate care, you get seen straight away, wheeled straight through. The receptionist doesn't get in the way, you just go straight through, and this is the way it should be. And the ambulances can ring in advance saying, I'm bringing this person in, we need to go straight into resuscitation bay. And you'll see on any report that the people who are in Category 1, immediate, must be seen now, their computer time is 100% seen on time. Now that's a figment of a clerk's imagination. You can never have 100% accuracy with this, but that's the way it shows up. But the reason why I say that is it opens your eyes to the fact that there is a little bit of gaming going on in this system. Category 2, which is actually much more common and much more important, these are people who need to be seen within 10 minutes. So somebody whose heart attack is causing them to go into shock, somebody whose asthma who is so extreme they can't breathe, and if they're not seen within 10 minutes to get proper treatment, could well die. So this is really high value stuff. Unfortunately, the performance across Victoria, across Australia for these Category 2 is woeful. Less than 60% of people in Category 2 get seen in that 10 minutes. Woeful, woeful. This is all open information. You can get it on the internet. That's where I checked it this morning. Some hospitals do better than others. The Alfred does well. Sandringham, Little Sandringham does well. But many of the other bigger hospitals in Victoria are doing really poorly for this very important. And this one can't be gamed. Remember I said in Category 1, it's all 100%. So that's the computer's making that decision. This one, Category 2, that actually requires the staff, either the nurse or the doctor, looking after that very sick patient to say, I have seen them and I've seen them now. And that is time-stamped on their computer record. And that's why we know it's only 60% that are being seen in that time. This is appalling. All of us should be shocked. Shocked? Thank you. Category 3, this is one of the most numerous groups, right? Just in terms of numbers. 3 and 4 are the biggest group. And the performance is better, but it's only about 70% seen on time. So this is somebody with appendicitis, you know, in pain, can't walk properly, needs to be seen, needs to have some pain relief. Maybe a person with a fractured hip could also be called a category 3, seen in 30 minutes. But only 70% are being seen in that time. That's not very good, because these ones are true emergencies. I think everybody agree they need something done very quickly. The non-urgent ones, this one down the bottom, about 90% are seen within 2 hours. So in terms of meeting the target, getting these people seen, the non-urgent ones, which is actually quite a small group, 90% seen in time. Long enough ago, I mentioned Box Hill, right? Box Hill started this system. They had seen immediately, seen within half an hour, seen within 1 hour, seen within 4 hours, seen within 24 hours. So that's how the system started, because they've actually said, this is non-urgent, you do not need to be here. You could go home to your GP, you would happily see him tomorrow, and your outcome will be no worse. And you can imagine how politically unsavoury that was. If you were to walk in, Derek, into Box Hill Hospital all that time, and they said, we're making you category 4, you could wait 24 hours to be seen, you'd be a bit upset. And clearly that was not palatable. So they took away the 4 and made 24 into 2. And to be seen in 2 hours is not unreasonable from a patient's perspective. It's not from a medical reason, it's more from a patient expectation. Not unreasonable. But I think the message from what I say here is that our current health system is not servicing the sick people as well as it should be. And you should be as horrified as I am that the government has allowed this poor performance to go on unnoticed. So, the importance of triage, as I mentioned before, greatest good for the greatest number. It's actually a very skilled task. The triage nurses are absolutely to be respected. They're highly skilled, highly trained, senior nurses who can tell just by the way you walk that it's appendicitis, or a footballer with a dislocated elbow, or a child with a supracondylar fracture. They have so much experience, they can just tell by the way you come in what level you need to be seen in. Very skilled. I've already mentioned that it can be gamed partly by the computer, saying, yep, 100% seen on time, but also if the triage nurse knows that there's a very long wait, you're not going to be seen in time. There is, unfortunately, a pressure on that person to down triage. The triage nurse will say, well, you're not going to be seen in 30 minutes, so I'll make you category 4, seen in an hour. So my colleagues have got a little bit more time to get things done. Very sad. We live in a human system. It's not appropriate, but it's nature. On the other hand, the triage nurse can up-triage you. Little child with a hassled mum and a couple of other kids. I want to get them out of the emergency department really quickly because that mum doesn't need to be here with 3 children. I'll make them up-triage to get this seen more quickly. And that's also fine. Remember, the patient comes first, not the computer. But triage is a science, but it can be gained. So, I come back to you're arriving at the front door. I want to see a doctor as soon as possible. Perfectly reasonable aim. However, there are medical surrogates. You might be seen by the nurse practitioner, a highly skilled nurse for particular treatments. So maybe a nurse who can do suturing, maybe a nurse can do plastering, maybe a nurse who can look after your asthma. And they do this as a solo practitioner because they've been trained to do that specific task, and they're licensed in Victoria to do that specific task and work independently. But obviously the triage nurse has had to decide, well, this is appropriate for the nurse practitioner. So it could be you're seen by a nurse practitioner equally as well as seeing a doctor. Maybe in some situations better. A primary care physio, so you go in with back pain or neck pain, you might not see a doctor at all. You'll see a primary care physiotherapist. and they're actually perform better for back pain and neck pain than doctors do, because that's what they specialise in. And they're right there at the front door to see you promptly, give you pain relief, give you the exercises, because that's their skill set. Makes perfect sense that the emergency department has people like that. You could see the ED nurse and doctor, which is 80% of what will happen, and that's why you're there. But they might also say, well, you could be seen next door in the GP clinic. And that's what Sandringham does, that's what Monash does. You wouldn't even know. They just say, go through the green door, not the blue door. But through the green door, you actually walk out of the emergency department, you've worked into the general practice clinic, you're being billed by Medicare, so no money out of pocket. Any x-rays done are billed to Medicare, so the hospital saves money, but also the whole quality assurance and the whole governance is done by a separate private company. You thought you were coming to the public hospital to get treated in the public emergency department. No, you chose to go through the green door. So you're now in a private GP clinic. For right or for wrong, they are with us. New South Wales has had these for years. They mostly go broke because there's not enough money to be made out of bulk billing people at these funny hours, because it's mostly in the evenings or weekends where the GP wants to get paid better and the Medicare billing doesn't allow for that. So these things mostly go broke. I think I'm right in saying there's one at Sandringham, which is now 8 years old, has had 4 different businesses running it. So, and it's heavily supervised by the doctor, by the hospital, subsidised. So anyway, be wary. It could be a good thing, but it might not be what you're wanting. On the other hand, the triage nurse might say, well, actually, your problem requires outpatient referral. You can be seen in 2 months in outpatients. That also happens, but very rarely. But this is the one I want you to be wary of. Are you going through the green door, and are you consenting to have this done through Medicare and without the protection that the public hospital system gives you? Just be aware. Alrighty, why are you going to see the doctor? Well, most likely it's because you want some treatment. And you want an answer. Why was I sick? Are these reasonable? But mostly you're going to emergency department because you want something treated. You've got pain that you want relieved. Or you've got a sprain that needs work or you need an X-ray. You need something done. And it doesn't matter whether it's the nurse practitioner or the ED doctor, they're going to go through these same steps. And this is where things can go wrong. They'll make a clinical assessment by asking you questions. We call it a history. They take a history and they do some form of examination. Now the examination could actually be quite brief. You might think, well, that doctor didn't examine me at all. But depending on what the situation is, it might be appropriate. So I get migraine. I'm sure many of you also get migraine. A horrible headache. I will go into hospital. I say, my migraine's so bad, please give me some pain relief. I will not need much of an examination. They don't have to give me a full neurological examination. They don't need to listen to my heart or chest, because I've said it, that's migraine. Let's get this over and done with. So that's quite appropriate. Where there are many complicated things that need a thorough examination, meaning taking all the clothes off, top to toe, and putting a finger in every orifice that they can find. You might think, oh, why did he have to do that? Well, if they want to find out what's going on, it might be necessary to do that. And I'm sure you've all read of cases where, especially female patients, have said, but he didn't need to do that to me. Well, in fact, he did. He should have explained it better. He should have got your explicit consent, but it was part of being a careful doctor to examine you top to tail, if that's what it needs. I make the point. So then you'll get your initial treatment, because that's why you went there in the first place. Yeah? You go there for treatment, you want to be relieved. There'll be some investigations need to be done, and this is where I'm going to go through some of the things that can go wrong here, and I'll touch on some of the decision-making processes. This is where you can help or hinder your own health by helping the doctor make better decisions. And then what you obviously need is definitive treatment. You know, you're going to go home with whatever, or you're going to be admitted with antibiotics, whatever it's going to be. And then the big one, can I go home today, or do I need to stay in hospital? Yeah, sure. Alrighty, I want some treatment. Okay, where are you going to be placed? If you came in by ambulance and they've rung ahead saying, I'm really, really sick, you hope to go into the resuscitation bay. And most hospitals, all hospitals, would have 2, 3, 4, 6 resuscitation bays right up the front with all the monitors. And that's where you want to be if you're really sick. But there's no privacy. This is all open. It's, you know, let the staff get in and do what they need to. For memory, Sandrington's got 2 resuscitation bays. The Alfred has 10, much bigger hospital. Monash has got 10. If you don't need that full-on resuscitation, it might just be a general care cubicle. A little bit to the side, a little bit quieter, maybe by yourself, which is often preferable if there are a lot of things going on. Might be into an isolation room. If you've got gastro and you need to be in a hospital, they probably want to isolate you so other people don't catch it. If you're coughing up blood and they think you've got TB, you'd be in an isolation room. If you're coughing up with COVID, they would have loved to put you in an isolation room, but the hospitals did not have enough capacity to isolate everybody, which caused no end of troubles. And obviously, we're all familiar the issue with sharing rooms, sharing air conditioning services with other people who are coughing COVID. So that's a bit of a problem that they had not thought far enough ahead in the planning of these hospitals 20 years ago to have any pandemic response. But I think they've now been told. You might go into a procedure room. We used to call these theatres. They're not really a theatre, they're just a procedure room where you can have plastering done, suturing done, have your shoulder relocated, something like that. So a procedure room. But all too often, people end up in the short stay unit. And a short stay unit, that's fine, it's a proper hospital bed, bolted onto the emergency department. But remember I spoke about gaming. One of the targets all around Australia is that from the front door of the emergency department to the back door of the emergency department, that should take 4 hours. 4 hours of assessment, treatment, all that sort of stuff. That should be done in a 4-hour time frame. And 10 or 15 years ago, we're doing pretty well getting the flow right. So most patients would flow through the emergency department and be seen in that 4-hour time frame. Then some clever bunny worked out, well, hold on, if I stick everybody in the short stay unit, I meet the target. Right? You go from the front door quickly through to the short stay unit, I can timestamp you, you're off the computer, I've met the 4-hour target. So it was gamed. And there are some hospitals, not in Australia, that the short stay unit would have 80 to 100 beds. It's huge, where the emergency department might only be 20, because they're just zipped through. So there are problems here. If you zip through too quickly, things get lost in the communication. Remember how I said you might be seen by the ED nurse and the ED doctor? Well, that's fine. They're your care team. But if they put you through to short stay, different care team. So you've been rushed through without having a proper diagnosis, without having the tests back yet, straight through to short, new team, new problems. So just be wary. Short stay is a terrific place if you go there at the right time for the right reason. But if all they're doing is shunting you into short stay to keep the computer happy, that's not a good reason for anything. So that's where spending time in a general care cubicle is safer, because that's the team that looked after you when you first came in. That's the team that got the history, got the information, and they're the ones that know which results are important to you. So be wary that too much flow to the right direction actually could be a problem. and short stay unit technically is the safest place in the hospital. True. Right? The death rate in short stay is very low, but the risk is high. Because these are people who should not come undone. These are people who should just need a few hours treatment and go home. They should have 100% going home rate, all going well. So, we've made a rod for our own back. But fortunately, Australia is using some sensible rules and governance over this, where in the UK it was just open slather and it was just woeful. So, getting the right connections. We want some treatment, we want a diagnosis. We need some tests to help. So medical imaging, everybody's had an X-ray, I'm sure. A lot of you would have had CT scans. Now there's more emphasis on ultrasound, MRI, terrific imaging, but they're not always available when you need it. You might have to wait 24 hours. There's a problem. We're trying to get flow. So maybe the doctor will take a shortcut saying, well, I know the MRI is the best test, but I can get a CT scan now and that'll give me 80% of the answer. And that's valid. You'll get 80% of the answer there and then. But there's always just that 20% doubt. Tricky one. Or they might say, I can't get ultrasound, but I can get an X-ray. Very different modalities, looking for very different things. That would be an invalid substitution. X-ray is readily available, but that's not going to tell you the things that ultrasound would. So we've got some issues here. Other one, pathology, blood tests, hematology, biochemistry, and microbiology. A lot of things like infections need to have microbiology to tell us exactly what's going on. Now that could take 24 hours or 48 hours. So not much point waiting for 48 hours. So this is where best guess is important. Looks like pneumonia, smells like pneumonia, I'll treat it as pneumonia, although I can't prove it till I have ABCD done. And I won't know for 48 hours what's the right antibiotic. So we have guidelines. In the setting of somebody over 65 who lives in Melbourne, who doesn't have diabetes, plain old penicillin may well be the right antibiotic. But in 2 days' time, we might find they need something stronger. And that's perfectly fine. You won't have come to much grief in those 48 hours while they wait for the definitive test. Some tests take time. Okay, so we've mentioned time frame. This thing about 24/7 access. I mentioned the 4-hour rule, right? Everybody's got to move through that door within 4 hours. And it doesn't matter if you arrive at midday or midnight. The computer doesn't care. The government actually doesn't care. But clearly it makes a difference if you're looking for a test that can only be done from in office hours. 40 hours of the week, and yet the emergency department's open 168 hours. So there are pressures to get things done, and there's also resource allocation. You can't have an MRI open 24/7. Way too expensive, and the cost wouldn't justify the outcomes we're looking for. Some tests have to go off-site. There was a devastating, tragic outcome. The recent local private hospital, they transferred a patient to another private hospital, and the blood test had to go to an off-site laboratory. The patient went from hospital to hospital. That blood test had the life-affirming information about what was causing this patient's unwellness, and that never got transferred to the next hospital. So just a communication issue, because it was done off-site. Appalling. Somebody died because that information didn't get from the laboratory to the end hospital in time. I make the point of the porters versus vacuum tubes. Now this is for little samples, getting a little sample somewhere quickly. Well, I could ring the porter, say, "Porter, can you come and take my sample?" And he'll say, "Yep, I'll do that." it'll take me 20 minutes. And then I know that that blood sample is going to take 20 minutes just to get to the lab. If I put it in the vacuum tube system, I've done my task, press the button, off it goes in the vacuum tube system. But it might wait at the other end for an hour. So that's no good. There's an hour wasted. Sometimes it's actually better to have somebody hand it, take it to the lab and say, hey, this one's urgent. So there's some interesting delays about using people versus just using machine. The samples that have to go off-site, and say from Sandringham, nearly all of the pathology after hours goes off-site, goes off to the Alfred. Or if it's microbiology, it has to go off-site. So do you spend 30 bucks on the taxi to get it done now, or do you wait 3 or 4 hours for the courier to take it? And obviously for the hospital it's much cheaper to do it by courier than a taxi every time. So these are some of the issues that go on in the decision-making process, and the delays and the errors. If it's done off-site, something could go wrong with the communication. So, how do we get around this? We have a system called point of care. I take your blood, I go to the little desk in the emergency department, I stick it in a little machine, doop, 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 doop. 2 minutes later, I'll have a result. Wow, that's impressive. I'm sure you guys have seen this if you go to the vet uses the same machine. Tiny little thing, no bigger than a old-style analog phone, and you put 1 drop of blood and it spits out this information. However, we have some issues with accuracy. You might have got that answer in 2 minutes, but some things, you know, that can't be right. That test can't be right. I'll wait 2 hours to confirm it from the laboratory test. So there's quick and dirty, or there's the definitive test. So it's not all straightforward. This works for pathology tests. Bedside ultrasound, I mentioned ultrasound before, a really good investigation. I've had some training myself, but I would not call myself proficient, but it gave me an idea that I can find your kidneys, I can find your liver, I can find a blood vessel. But it's very operator dependent. If somebody doesn't use the machine correctly, their results are way off. So we have an issue here that it's readily available, it's right next door to you, but if you're not properly trained to find that thing, then it's really not doing anybody any favours. I'm sure you're all familiar with an ECG. All of us have had an ECG at some stage. That's a bedside test. But fortunately, the machines now spit out an answer. Because long enough ago, when I did my training, we had to put them on each little dot individually, and then we got a strip that was this long, and we chopped it up into little bits and put them in the right order, and then we wrote what we thought was going on. Well, the accuracy of that was less than 50% in acute cardiac settings when it really matters. The accuracy of the initial ECG was only 50%. Fortunately, we now have machines that will say, alert, this person's having acute heart attack, even if the machine is right or wrong, but at least it's raised the issue. So we are being benefited by this technology, and you as patients or friends, relatives are benefiting from this as well. It's taken a lot of the guesswork out. Okay, now I don't need you to read these. The point is, we've now got allied health. We've now got another layer of very important people in the emergency department that are part of your care. Especially pharmacy, because a lot of it's about drugs, obviously. Especially physio, because a lot of it's about getting you moving again. And I'm not discounting the dietitian, but the dietitian, their role in the emergency department is smaller because you're only going to be there for 4 hours, all going well. And the dietitian will catch up with you on the board if that's what needs to be done. But it's another layer of communication, it's another layer of complexity, it's another layer where things can go wrong. Okay, then it gets worse. I make a referral to my medical colleagues. I'm the emergency doctor. I see you in the emergency department. I'm going to refer you on to a surgeon or a physician or a cardiologist. I've got a huge number to go that I can choose. And this is what emergency medicine specialists do. We make the initial diagnosis in the time frame with the tests that are available to us. We don't have the 24-hour or 48-hour luxury. We have those few hours to say, the problem you've got is probably what the cardiologist wants to see. Or the problem you've got needs the general surgeon, not the colorectal surgeon, not the biliary surgeon, not the hepatic surgeon, not the vascular surgeon, but this is going to be a general surgical problem. Or orthopedics, that's obvious, the bones. So these are the ones would be our common referral sources. But obviously there's every specialty there, and the list goes on and on and on. But this is what an emergency doc does. We're a jack of all trades. I'm not a surgeon, I won't take your appendix out, but I will stitch up your wound. I will make the diagnosis of diverticular disease, or make the diagnosis of appendicitis. I'm not a general physician, I'm an emergency physician. I'll diagnose your pneumonia, I'll work out whether it's a heart attack. I'm not a psychiatrist, but I certainly know if you come and you've got depression or mental health issues, I'll refer you to the right person. I'm not a plastic surgeon, but I'll stitch up your wound. I'm not an orthopedic surgeon, but I'll pull your joint back into place, pull your hip back into place, set your bones. So an emergency specialist is a jack of all trades. We make the diagnosis in a short amount of time with the resources available to us. So, the specialist service. And this is what has changed over 40 years. I'm sure all of us would recall the days when Box Hill had such a bad reputation, you wouldn't want to go to Box Hill. Who heard that? Yeah? I'm exactly right. And way back then, it did have a bad reputation, but it was doing a remarkable job as a little guiding light for the rest of Australia. It seems hard to believe that their reputation could be so bad, and yet what started there with triage has made a huge difference over the whole of Australia. We now have a College for Emergency Medicine. A college is a professional organisation. I'm sure all of you have had contacts with your various professional organisations. Our college is only 40 years old. It supervises all of the training of specialists in Australia and New Zealand. It sets the examinations. It sets the standard for emergency care. It accredits ongoing specialists, so everybody has ongoing professional supervision. It accredits hospitals for training, including private ones. So the Epworth is an accredited training hospital. Cabrini is an accredited training hospital. But Knox has been. I don't think it is anymore. John Faulkner is not. But a training hospital means they have trainees. Trainees are on their way to becoming a specialist. So in fact there's a risk balance here. You might see a trainee who is only half trained, quarter trained. Or you might see a trainee who is just about to become a specialist. So it's not the accreditation of the hospital itself that determines the level of care. Every public emergency department is a training centre. So there will be interns, second year doctors, registrars, junior registrars, senior registrars. So you may well see a junior doctor and say, oh, that doctor, he looks way too young. Don't they? Don't they all look way too young? They do in my eyes. And he doesn't know anything, he looks way too young. But in fact, he might be a 30-year-old specialist in his own right. Tricky. But the important thing is we do provide a specialist service. So there's a level of training. 5 years of training on top of the 2 years of basic training, so it's 7 years minimum on top of university training. What's that? 13 years of training to become an emergency specialist. But this doesn't mean we don't have general practitioners in our emergency department. There's an important role for both. General practitioner comes with a different skill set, often better at knowing how the community is working and what works in the community, because they have experience in the community. So when I've made slightly disparaging remarks about walking through the green door to see a general practitioner, that wasn't because you're going to get a lesser level of care. It's just a lesser level of governance. Different issue. But the GP has a very important role in an emergency department, and I've worked with GPs at Royal Melbourne Hospital, Monash. The Alfred didn't have, oh yeah, the Alfred had one GP. Certainly here at Sandringham, that was one of the things I really promoted, was the role of GPs, and Dandenong Hospital. All had GPs as a valued part of their emergency staff. And they enjoyed it from the team experience. Rather than a GP being in his room by himself consulting, they're then part of a department with a team. Worked both ways. Okay, it's about flow. I'm sure all of you have heard about the horrible ambulance ramping, and it's true. And it's a scandal. It should never have happened. It's just woeful that our health technocrats, bureaucrats have allowed this to get to this stage. Should have been stomped on day one. But it was allowed to happen. It has so many ramifications. Ambulance is one of our prime resources out in the community. They should be treated a lot better than they are. And ambulance ramping needs to disappear. Yes, we have overcrowded waiting rooms. Yes, you'll have a long wait to be seen. Yes, you'll have a long wait for tests, as I've explained about the 24/7. Yes, you'll have to wait for medical decisions, but you can do good things and bad things. There may well be a long wait for a bed, and maybe a long wait if you're well enough to go home. I'd say lucky you, but you're on your way home. Unfortunately, these are that 4-hour rule, right? And Victoria's doing really poorly with the 4-hour rule, getting people through. But actually, you don't want to rush a good decision. Here's the balance. Maybe waiting an extra half hour to get the right decision is better for everybody, rather than being rushed through the door prematurely. Anyway, let's talk about the ambulance ramping, because I think all of us need to be involved with this. Fortunately, Bayside area does a little bit better than the rest of the state, and the rest of the state's doing poorly, but we're not doing as badly as South Australia or Western Australia. They've got a woeful situation. But it causes, and is caused by, an ambulance shortage and a crew shortage. If you've got your ambulance staff sitting in the emergency department in the corridor waiting for their patient to be taken over by the staff, well, that ambulance crew is not out on the road going lights and sirens to pick somebody up. And this shows in their ambulance statistics. They are not as good as they should be, although they have improved marginally over the last 12 months, which is a good sign. But it is woeful because of the ramping in hospital. The hospitals have to get their act together. The hospitals have to take these people off the trolley and get the ambulances back going. Alfred does it remarkably well. Sandringham does it remarkably well. Every other major emergency department is really very poor. So it's a decision made by that organisation, you know, to prioritise ambulance patients and get them off, or you just let them wait. Somebody else can look after them. So it's a political decision we all need to be aware of. But these are clearly unproductive hours and bad for the patient, bad for the community. Interestingly, long enough ago we had what's called ambulance bypass. I'm sure many of you in the business world, you'd work out that if that part of the production is overloaded, you might do better to send your surplus over to this other part and spread it around. And that's what bypass used to do. That hospital was so busy, we'll redirect the ambulances elsewhere. Now, it was unpopular, so that the health department got rid of ambulance bypass. They don't bypass the hospital anymore. They go to these crowded hospitals and they sit there and wait for hours instead. So, no-brainer to me. They've made a mistake. Ambulance is failing to meet their targets. Part of the problem is stay and play versus grab and run. Now, I've spent very little time in an acute ambulance, but I have spent 8 years doing retrievals around Victoria. So I have seen a bit of Victoria, but that's not acute primary ambulance. So I'm talking out of my field. That if a patient, if an ambulance spends an hour at home with the patient, I'm going to call that stay and play. because they're doing things and giving treatment there and then. It might not be bad, but it takes time. Where if they grab and run, they spend 5 minutes, grab, take them to the hospital. Now, both have to happen. I'm not saying one is right and one is wrong. Both have to happen. It's got to be for the right reason. And it should be audited. And that's what's not happening. Nobody is auditing how much stay and play versus grab and run. And that's a problem. But it's an important service, and it needs, basically, got to start at this end. The hospitals have to release the ambulances promptly, and that the system will improve dramatically. Yes, there are alternatives. Telehealth, private ambulances, or a taxi. You can ring the ambulance and say, is it an emergency? You say, oh, well, sort of is. I want to talk to somebody about my chest pain. And they'll put you through to a clinician to work out, oh, could you go there? Could you see your GP? I think this is wrong. The ambulance should be about promptly getting people to the ambulance, to the hospital. How are we going for time?
Couple more minutes.
Couple more minutes, excellent. All right. Overcrowded waiting rooms. They've made the waiting rooms smaller. They've reduced the amenity because they don't want people to wait in their waiting room. They have to have a junk food machine. But you'll notice the chairs, you can't lie down on a chair. The chairs will have arms, so you can't lie down because they don't want people to lie down. Think of this. You might be sick, you might need to lie down. But they've made them worse. They've put a waiting room nurse, so you think you've been seen, but this is a waiting room nurse. This is not a nurse practitioner. They're not highly trained. This is not the triage nurse. This is a waiting room nurse. They're still part of the team. At least they're advocating for you, but they've gone backwards. The ambulance corridor, I don't know if any of you have seen the ambulance corridor at Monash, but it make you weep. Dozens of patients on dozens of trolley with at least 20 ambulance staff just sitting there in purgatory going nowhere. It's just, if you took a photograph of it, you'd just be horrified if that ended up on the front page of the Age. And that's why the health minister doesn't want to know about it. It would immediately upset any government if that corridor was on live television. It's just extraordinary. Another trick is to put a doctor on triage. Now the doctor's not trained in triage, the doctor's trained in doctoring, not triaging. Very different skill, but it makes you think you've seen the doctor. But the doctor can do very little in a public space through a glass window. But again, this is one of the desperate measures that hospitals are doing to try and fix the computer time, not help you. Remember, patient comes first, not the computer. I'll skip over triage away. Okay, long way to the scene. I think we can go through this. Okay, I just want to spend a few minutes on the decisions, because this is where you can help or hinder. Doctors and triage nurses use pattern recognition. I've mentioned the appendix, and next time you see somebody walking like that, you'll say, appendicitis. Or you'll see a footballer like this, you'll say, dislocated shoulder. You're probably going to be right. We've got issues with the tests and biases, and this is not just in medicine, biases in any decision we make. When you choose which health insurance you're going to have or which hospital insurance, you're using these biases. And obviously fatigue. Everybody knows about fatigue. Okay, pattern recognition. It's very efficient care if somebody can see as you walk in and say, aha, you need to go that way because you're that unwell. And obviously those decisions are made within seconds. So long as they're right, it's in your interest. I've mentioned about the triage, and I've mentioned about specialists, why we have specialists for the last 40 years, because they are jack of all trades. A specialist has 30,000 clinical images in their head. That's what they spend those 13 years learning, the 30,000 patterns. Now, if I get that pattern wrong, ouch, that's not good for you. But if I get it right 99% of the time, it's good for everybody. But there are obviously issues with bias. I've mentioned about the ECG interpretation. 50% error on the first ECG. Two solutions. Have better trained staff, get a second opinion, get a second ECG. So there is the simple ways around this. Medical imaging, have a look at this one. Oh, it's coming up. This is how we're trained. A medical student hears clip clop outside the window and says, aha, it's a... Oh really? No, a medical student will say it's a zebra. Because that's how medical students are trained. They're trained in what we call fascinomas. The little things that are so obscure, out of the way. So we have to retrain them to get the 30,000 pictures of the images. But that's how all medical students are trained. They think it's a zebra. Unbelievable. Alright. Now, when you go home, Google this one. Find the gorilla on the CT scan. 83% of radiologists got this wrong. 83% of radiologists got this wrong. They were asked to look for tumour on a CT scan. Here's the gorilla on the CT scan. 83% missed it. These are trained radiologists. It's about pattern recognition. If something is unusual, you won't see it. We all fall into this. Please Google finding the gorilla on the CT scan. It's the most extraordinary thing. Okay, when things go wrong, choosing the right test. I'm sure all of you have had a rat and were grateful when it was negative. Yeah? Rat's clear. I can go out now. I can go to the pub. The accuracy of those rat tests was abysmal. Abysmal. We would not rely on that in an emergency department. PCR, much better test. You choose the right test. You get the right answer, or the answer you're looking for. Ear thermometers. I'm sure all of you have had an ear thermometer. They only pick up 2 fevers out of 3. Woeful. But it's really easy. So the trick is to do it again and again. Or have a look in the ear, see how much wax there is. It's all about how it's used. But a very poor test if you're looking for somebody's temperature. X-ray looking for wood splinters, as I mentioned. Woeful test. Ultrasound, much better. Ultrasound's not always available. Or the arrogant doctor might say, oh, I've done a bit of ultrasound, I'll have a go. Even worse. Single ECG we talked about. Okay, availability bias. In the middle of a flu epidemic, every person with a cough and a heavy breathing is because of flu. Wrong. Could be pneumonia. Could be a heart attack. Could be any untold number of things. But all of us have the sort of human failing to make these errors available. Because it's available, we'll be biased towards that. After Christmas lunch, indigestion is because of overeating. Now I worked something like 28 Christmases out of 30, and to me the most scary thing was to work out which one of these was having a heart attack. Because to send a heart attack home on Christmas Day, very bad karma for everybody. Alright? After Christmas lunch, indigestion is not because of overeating. It could well be because of a heart attack or something else. But this is the issue of availability bias. The other one that we fall into is confirmation bias, or it's called anchoring. You're anchored to that one idea. Now remember the very first thing I said was, well, the ambulance comes in saying this is angina, or the family doctor said I'm sending this person in because they've got something or other. That anchoring bias could go all the way through the decision-making process. It looks like a duck. It quacks like a duck. Its neck's too long. It's very big. It doesn't fly. I'll ignore all that. Ignore all the red stuff, because that doesn't fit with me saying it's a duck. All of us have that ability to make this kind of error, confirmation bias, or anchoring. When things don't fit the pattern, we choose somehow in our brain to ignore it. Doesn't matter whether you're an emergency specialist or an accountant or whatever. We can all make confirmation bias. Okay, nearly done. Therapeutic trial. If the treatment works, then that defines the diagnosis. Now remember earlier on I said you're coming here for treatment and an answer. So if I gave 50 of you an antacid after lunch, right? Well, some of you will get relief because you had indigestion. That makes sense. But if I gave antacid to 50 people having angina, some of them would get relief from that antacid. Antacid is not a treatment for angina, but they will still get relief. So that would be a huge problem if I said, you had relief, therefore this is indigestion. So, but sometimes it is accurate. I give an antidote to a specific poison, that works. Antidote works, that means that poison must have been that poison, because I gave the antidote, and it works. It can only work for that particular drug. Or Imigran or the other sumatriptans, right, work really well for migraine. They won't help any other sort of headache, but they're really good for migraine. So that would work. All of us have heard of placebo effect. I give you a little blue tablet. If it's bitter, you'll probably get some relief from whatever your problem was. And that occurs between 10 and 30% of cases, just because it's a small little bitter pill. Figure that. Something about psychology, expectation. But that doesn't mean that I've made it a diagnosis. I've just relieved your pain. Nearly done. Double checking. This I find absolutely fascinating. I ask you to double check my maths. Have I given the right dose? That person is going to say yes, because I've given the thing. So double checking actually doesn't work very well. It'll make the same error. The best way is to have one person check it by two different methods. So it's actually better if I sit down and get a calculator, and then I go over here and then I look it up in a book. If I've double checked it, it works well. If I ask somebody else to double check it, they'll just approve what I've done. Awful business, awful business. And yet, our policy over every hospital is that nurses should double check. And yet, they're still going to have similar errors. Extraordinary. Okay, so what went wrong to our first-class system? We still have a first-class system. We still have one of the best public health systems in the world for the amount we've spent on it and the outcomes. It sure could be better, but it was not because of a pandemic. Don't let anybody tell you, it's just a pandemic and now it's all getting better. Wrong. This is years of underfunding. The last time it was properly researched, properly funded, was 2007 to the period 2010. And that's when there were various government supervisory bodies monitoring it. Now you could say, well, did we waste money on those government supervisory bodies? But they were doing their task and showing where the problems were and funding to meet those problems. But since 2010, it's been a slippery slope ever since. Shared state-federal funding issue. It should be 50-50, or be brave and just give it totally to the states. This does not need federal funding. This could just be totally done by the states if the states were given enough money. Interestingly, the splash that was made during the pandemic fixed a lot of problems, briefly. That extra funding was withdrawn and the hospitals went, and now they're gradually working their way up. It's awful. But the governments of all colours have taken their eyes off the ball. It's there to be seen. I'm just... Well, it's about spending the money appropriately. It's not just about splashing cash. It's about spending the money where it needs to go. All those measures are available. They're on the internet. I had a look this morning for breakfast just to give me indigestion before coming here. But it's all there, and truly it's on all of us. We're Behoven, all of us at Behoven, to take it to our local member and say, hey, local member, go and visit Monash Medical Centre one day, and then go and visit the Alfred. Why are they chalk and cheese? One's got it right, one's got it wrong. I can say that. I've worked at both hospitals. But clearly it's as obvious as that. And their performance is there for everybody to see in the public workspace. I think I'm done. Thank you very much. This is the Gordon River. This is where I was a couple of weeks ago, motoring up the Gordon River. A beautiful spot. All of us need a little bit of out time. But thank you very much. I'm not sure I've left time for questions.
Gentlemen, we're getting close to running out of time. I think we can squeeze 2 short questions in for James, and that's about it. So anyone got any questions for him? Over there, Tim?
It was indeed a very interesting and useful talk for this audience. I just had a question. I know that nurses can give injections that are prescribed, but in the ED department, can the nurse practitioner decide that you need pain relief on their own?
Yes,
Oh, good.
there may not be an injection. It might be a tablet. Depends on that individual nurse practitioner, what level they're accredited to
Yeah.
and what's been approved in that hospital.
Yeah.
But in different settings, they can give injections,
Yeah.
but in Metro Melbourne, probably be a tablet.
What about the ED physio?
ED physio, good question. I think they can give a level of medication, but not narcotics. But why they do so well, they do it without narcotics. And that's why the physio, in fact, is better. If you've read about the endone controversy in America, you'll see that drugs like endone shouldn't be used for many chronic conditions. And the physios are on top of that.
One more? Anyone?
Going on.
Quick, Tony?
Private EDs like Homescan, are you better off going there to get quicker treatment to go to Sandy, or would you suggest?
All
that better
is
go to
true.
Sandy?
I've been a patient at Homespan myself. I've been a patient at Sandringham for different things. The Homespan has an intensive care, so it has all levels of specialty intensive care. Sandringham doesn't have an intensive care, it doesn't have a cardiac unit. So handy Sandy, great place to go and be seen initially, and then they work out, well, are you going to go to see your usual practitioner, your surgeon, for example, if they're at Homespan. But be confident that the emergency departments here will see you with an appropriate level of care, and you decide whether you want to pay the $495 out of pocket. It's your decision. But it's a discussion to have also with your, if you already have a physician or surgeon, which hospital do they admit to, and would they rather you went through Sandringham or Homespan? But I've been a patient myself at Homespan.
Thank you, James. It's a fantastic talk.
Thank you very much.
I call upon Grant Saban to give the vote of thanks. The necessaries.
Well, I'd like to thank you for a very vibrant and stimulating presentation. I'm not sure how our confidence goes.
Absolutely. No, it should build confidence. We have a first-class system. Thank you very much. This is a health food of the nation. Well done.